Set. Hello everyone, and welcome to the monthly case webinar series. My name is Seidel. I'm the customer success specialist at Leighton Minds Radiology. I'm very amazed now because all of you have joined live today, so it's a big number, and I think that's an indication that we're continuing to provide a valuable webinar for you. With that being said, I'm very excited for this webinar because, as always, we have Dr. Imran Lasker, who specializes in MSK and general radiology. But we also have our guest speaker, Dr. Samir Alban, who specializes in pediatrics, and he also worked for Chelsea and Westminster Hospital. With that being said, I will send the case collection in the chat where you can go through the cases together with Dr. Lasker and Alban. I'm going to be your host, and if you have any questions, please use the chat function on Zoom or email us at cmrad.com. Or support@cmrad.com. So I will stop talking now. So please, Dr. Lasker and Alvin, please take the floor.
So hi everyone, hope everyone's well. We've got a few people turning up today. Samir Alwan is a good friend of mine, and he is going to basically teach me how to do pediatrics, and hopefully the rest of you guys as well. So without much further ado, I guess I introduce Samir Alwan again. Samir, do you mind just sharing your screen? So Samir is a colleague that I've known for a very long time. For some odd reason, he likes pediatric radiology. He didn't like MSK radiology, despite my best efforts to tell him it's the wrong thing to do.
Yeah,
but anyway,
hi, Imran. So, and everyone else. I'm not in it for the money like the rest of these guys.
Oh,
sorry,
of course.
so I'm Samir. I'm a radiologist at Chelsea Westminster Hospital, as Seidol's already said as well. So today I'm just going to go through a load of different cases and just show kind of how I go through pediatric imaging, and me and Imran will have a little tete-a-tete as we go along as well. So cool. So without any further ado, I will get started on the first one. So again, if anyone's got any questions, just send them in the chat, and then we can have or if you have any ideas about what it is, and just let us know, and we can go from there. Sweet. So now, so let me know, Imran, you can see that, and I presume everyone else can as well.
Yeah, I can see that. It's one of those lines one, isn't it? You're going to tell us about the lines. Go on.
Exactly. No, you know me too well. So perfect. So, I mean, this is one of those cases where we know there's something going on, but let's not focus on that for now. Let's focus on the other stuff first. So, pediatrics. If you're ever going to look at pediatric X-ray, I know it's simple, but let's always start at the lines. Let's not forget them, because it's very easy to miss the bigger things sometimes in all of this. So let's start by choosing which one's which. So let's start the easy ones ahead of anything. So this line here that we can see coursing down and going into the stomach, the NG tube. Okay, I'm not going to that's not too exciting. Don't need to delve too much into that. Obviously, we want to see it in the stomach. The other of the lines, which is a little bit easier, is the ET tube, which you can see up here. So if I just zoom it, and the way you can always tell the ET tube is it's got a continuous solid line on both sides as well throughout on there. Now, in kids, the ET tubes are slightly different. In adults, we say, well, it should be 2 centimeters above a carina, or, that kind of thing as well. But in kids, it's slightly different. They have very short necks, and the ET tube moves a lot. So in theory, we try and say it should be at the level of T1. In practice, that's wishful thinking. A lot of the times it flips back up and down a lot on there. So really what we don't want to do is see it going all the way into the, to the carina or into one of the bronchi, and we want to see it in the neck, i.e. not sitting all the way higher up as well. So they're the two easy ones. Now, what are the other two lines that we're looking at here?
Like UAC or something. UAC and then the UVC.
Yeah, and do you know how to tell which one's which on there?
Isn't the UVC the one that kind of coils downwards and upwards again? Have I got that right?
Yeah, well,
I got it wrong.
Not so.
Oh, there you go. This is why I'm not good at peds. Go on.
So there's only really one way of telling it. So the UAC, the umbilical arterial catheter, is the one which coils down, and it can be a bit tricky sometimes, because obviously when it's external, it may look like it's coming out and it's coiling down as well. So always be a little bit careful. So UAC, which is this one here, and let me just annotate it, is this guy here. As you can see, it's coiling up. Going around. So this is the UAC. And the UAC, basically what happens is anatomically, the UAC is going through the umbilical artery, going down into the iliac artery, and up into the aorta. So you should always see it curl down and then go back up towards the aorta. In terms of position, there's two positions normally. Now, there's a high position and a low position. The high position is one we classically see. Low position you see less commonly, but you can still use it. Any ideas as to where we put it? Sort of?
I mean, you'd go above the, I mean, into the atrium, no? Kind of quite far up.
Yeah, so in terms of, well, for the UAC, what you want to do is just avoid the renal arteries coming off aorta. So you want to avoid between levels of T10 to L2. Some people say L3 on there. So anything above T10, ideally around T8, T9 is probably best. Anything below L2 or L3 is also best. The UVC is slightly different. So the UVC is this tube, which is coming along here and then going up here. And this has a very straight course. So again, anatomically, goes through the umbilical vein, then it goes into the left portal vein via the ductus motus, and then goes into left hepatic vein and then into the IVC. And this should sit at the level of the right hemidiaphragm or the inferior cava atrial junction as well. So I'm not going to delve too much into the boring stuff on there, but just to not forget the lines in any of these cases, because it's always something you want to be careful with. So what's going on here? Any ideas? Anyone has any clues? To send it in the chat and we can see what people's train of thought is on there.
Yeah, someone's come out with something. You see?
Yeah, do they look like they know what they're talking about here as well. So
yeah.
So in terms of this, so yeah, a congenital diaphragmatic hernia. This is a really classic example of it as well on here. Now, what are the things we're looking for with CDH? Firstly, what you see here is multiple cystic lucencies seen throughout the left hemithorax. The other key thing to note as well is the left diaphragm is clearly indistinct as well. You can even see some of this is contiguous with these loops of bowel that you can see going into the chest as well. Elsewhere, if you go further down, there's a real paucity of bowel gas in the abdomen. In fact, all you can really see there is the stomach as well, maybe a little bit of bowel there too. So what's the other things to comment on, which is really important of these things? If anyone has any clues, to send it, or if Imran, you want to enlighten us as well. So.
I mean, you'd be worried about obstruction, I guess, in these situations. I mean, the bowel's gone all the way up there, no?
Yeah, I mean, that's one thing to worry about. And yeah, I think Mara has said it perfectly. The other thing is the mediastinal shift as well. And specifically, it's not so much the mediastinal shift, it's the shift results, therefore, in a degree of pulmonary hyperplasia. So if there's lots and lots of mediastinal shift, then clearly there's not much aerated lung. And the thing that kills these kids is actually the pulmonary hyperplasia a lot of the time. So as you can see here, there's a significant shift to the right-hand side with very little aerated lung left on there as well. Now that's important because before you want to start delving into all this fixing this CDH, you want to sort out the lungs and try and optimize it first. So often these kids are optimized with very high frequency oscillating oxygen, and they try and sort this out, try and improve the aeration of the right lung or the unaffected lung before they operate on them as well. So classic CDH, you've seen it once, you've seen them all, they all look exactly the same. Okay. Right, so let's move on to the next one. So,
got a few good answers there, actually.
Good.
Okay, yeah.
So let's go to this
case. Number 6.
Right. So any thoughts at all on this one?
Well, loops of bowel look quite dilated, don't they? So it looks like a small bowel. It looks quite central.
Yeah.
Also, actually, you know what? Okay, I might be wrong here, but there is that linear line going down sort of diagonally across the abdomen. So could this be a perforation of some sort because you've got this? Well, essentially, it's a falciform ligament. Yeah, is that the one? Yeah.
Yeah. So I think that's probably just overlapping bowel loops on there as well.
Yeah.
You can see it goes very, very low down as well. So I know a few people in the chat have said it, and I think they look like. Yeah. So we've got a couple of comments on there about bowel obstruction, necrotizing enterocolitis, and that's where the money is on there as well here. So before I get on to necrotizing enterocolitis, I mean, the key thing first is obviously there is bowel dilatation. So Imran, you said that, for example, he said there's small bowel on there. So sometimes it's really tricky in kids to say. And in kids, obviously, it works differently to adults. Firstly, what is dilated bowel? not always clear cut. In adults, we have that 3-6-9 rule. So, 3 centimeters small bowel, 6 large, 9 cecum. In kids, it's quite different in that, firstly, it's very difficult to often tell if it's small bowel or large bowel affected. Sometimes you can, but especially when they're neonates like this, you don't have the haustral pattern, for example, the valvulae convente, are not as easy to appreciate. So with that in mind, sometimes you have to just say it's just bowel dilatation, firstly. What you do want to do ideally is try and park it into a certain category, i.e. is it high obstruction, mid-gut obstruction, low obstruction. But like I said, a lot of the times you can't tell. So in this case, quite difficult to tell exactly what type of bowel is dilated on it. And in terms of is it dilated, well, eyeballing it clearly is. There is a way, I mean, some people use the width of the vertebral body. So if we were to go across this way, sorry, that was a terrible line, on there, and then you compare that to the bowel, and that is how you determine if it's dilated. Personally, I don't use it much. I don't think it adds an awful lot. For me, it's more of a eyeball it, see what it's like, and I think you can kind of tell here clearly it's dilated. So in NEC, the key things are obviously there always should be bowel dilatation. If a bowel is non-dilated, it's got to be, unless there's a real paucity of bowel gas and the bowel literally looks like it's fluid filled, it's got to be unlikely to be NEC. The most common thing we see with NEC is a fixed dilated loop of bowel on there. So if all the bowel is non-dilated, it's probably going to be unlikely. So that's the first thing. So you've got dilated loops. I feel like I'm talking about dilated bowel loops for 5 minutes here, but then what's the other thing? So the other things are, if we look here, now this can be a bit tricky. Can you just, if you can just see here, you can see these little lucencies in the right flank, and probably actually if I zoom out, it's actually a bit more apparent on there as well. So yeah, if you compare the right hand side to the left, you can see there's this sort of bubbling or mottling within the right flank. Now, obviously in children of this age and neonates, generally their bowel is fluid filled, so you don't really see, and they're obviously fed largely fluids, you don't really see that fecalization that you see in adults. So seeing feces like this would be unusual. You do occasionally see it, but you always have to be a bit suspicious. So we see this, combine the two together, this obviously is pneumatosis, a bowel within the wall of air within the wall of the bowel. Other things to look for when you're looking at these kind of cases, if there's pneumatosis, look for portal venous gas. So you look over the right upper quadrant, nothing there. And then always don't ever forget looking for a pneumoperitoneum as well. So, and that can be really, really difficult, especially when it's like this, where there's loads of gas everywhere. Going back to what you said about the falciform ligament, I think as you said, it descends very low down. I think it's tricky with kids because it's a lot of overlapping loops. So what do they do for these? Well, normally do serial radiographs and bowel rest. And if we give you another x-ray, so this is taken a day later, and there you can see much, much easier to appreciate the pneumatosis and intramural gas as well. Cool. So that was that. Right.
So, I mean, this is obviously someone who's quite young, so there must have been like recent, I mean, they're going to be newborn, because this before having a diet, like actually like having much in, or, I mean, how do you know? Yeah.
How do you mean? Sorry, man.
So, I mean, you're saying like they shouldn't have feces, right? So is there an age at what point that you would be expected to see feces, or is it they're just going to always look like they have liquid inside their bowel?
So I think it's normally in the older kids. So, literally up to about 1 year of age. I don't know the exact age was, but up to about 1 year of age, it's quite common to see that, where there's not much in the way of mottling or feces that you would see normally. Like I said, it's not a hard and fast rule. You do see it, occasionally, but if the clinical history is suggestive of it, then you've got to be a bit suspicious of it as well.
Okay, fine.
So that was that. Preterm kids are the ones who get that most commonly. So that's another thing, although not entirely limited to them. I know we get taught that, but you do see it in the term children as well.
Okay.
Right. So I'm going to start off with more of abdominal and chest things. I'll move on to some more juicy stuff as well. All right. What are the thoughts on this?
What case are we on? Okay. Well, quite that real paucity of bowel gas. Oh, there's also this calcification located within the right abdomen. Yeah. So I mean, you're concerned about if you've got a calcification in a child, you're thinking you're a blastoma straight away, aren't you?
That's definitely a good consideration on there.
Okay.
Anything else? Or if anyone else wants to shout out, I know Marwa, I think's already gone straight in there.
There you go for it. Duodenal atresia.
So anyone else? Any other thoughts? Imran, you were kind of there, but if anyone wants to add to that, Natalie Kernan, that name sounds very familiar. Yeah, so I think we've got it.
Oh, there you go. That's the one. That's the one. Yeah.
So,
got it.
So we got there in the end. Now it's not like no one has nailed it at the moment. It is there and amongst all of that, but bear in mind there's a couple of things going on here.
Okay.
So what are we thinking here? Well, firstly, so if we zoom up a little bit. So I didn't say much about the lungs, but I'll get onto those in general when I show you a chest x-ray in a bit. But the lungs are very unremarkable, normal cardiothymic contour, normal NG position on there. But we get to the abdomen. So there's two things here. So yeah, as Imran and some of the guys in the chat said, we've got this area of calcification in the right flank. We'll get onto that in a second, but let's not forget this as well. So this is a classic double bubble sign that we see. So you've got, even despite the presence of an NG tube, you've got a dilated stomach and a dilated duodenum. Now, what is the key thing after you've seen that do you want to comment on next? If anyone wants to say, or any thoughts, Imran, on how I'm testing you today?
And the only thing I thought was the paucity of bowel gas and the rest of the abdomen, right? So that you've got, I think someone said it is a duodenal atresia. That'd be one of the things I'll be thinking of. Is there some sort of developmental issue with regards to the rest of the bowel?
Yeah, exactly. Yeah. So the key thing, whenever you see this double bubble appearance, although classically it's duodenal atresia, don't always forget the other things as well on there. So you want to see what's happening distally as well. So distally, there's no bowel gas whatsoever. So we've got what is almost certainly a complete obstruction. So in this instance, it is duodenal atresia. But the other things you're considering as well are, for example, duodenal web or an annular pancreas as well. In those instances, you would hope you would normally see a bit of distal bowel gas as well. The other consideration as well, if it is in a very acute setting, is a malrotation of volvulus as well. And that's actually probably one of the quite common things that we see as well. Again, you know, a lot of the times in those cases, you do see some bowel gas, classically those ones where you get a corkscrew appearance on upper GI studies, whereas they obviously have a little bit of passage of contrast, but a lot of the time it is just a complete obstruction like this as well, but there'd be much more of an acute presentation. So, and anyone knows, you don't know what kind of children or who gets this duodenal atresia? Any thoughts? Yeah. Mara's got it. Yeah, there you go. Yeah, so kids with Down syndrome is a common one. So the other good thing to always look for is to count the number of ribs. You either have more ribs than you'd expect, 13 ribs. You have 12 paired ribs on it as well, which in this case they do. So that's point number one. Point number two is this guy here. So this area of calcification, the right lower flank. I think a few people said it as well. So calcification in the abdomen. If I'm looking at abdominal X-ray, in general, don't overthink them. Firstly, if I'm looking at abdominal X-ray in a kid, first I'm looking for, are there dilated loops of bowel? Yes or no. If you know, is there new free gas? Yes or no. Is there pneumatosis? Yes or no. If there is pneumatosis, I look for portable venous gas. The other thing I always want to make sure to look for is there calcification. So if there's calcification, as Imran said, the thing you always worry about first and foremost is neuroblastomas. They're the most common abdominal mass to calcify in kids of malignancies, most common abdominal malignancy, sorry, to calcify in kids. The other things though, is this. And this is a bit of an unusual one because you've got this calcification. Now this wasn't a neuroblastoma. This is a newborn, obviously, given the fact they had a duodenal atresia as well. And this was actually due to a meconium peritonitis. So, which in itself is a little bit odd because we've got an obstruction, but intraoperatively it showed a perforation of a transverse colon as well. So we've got dual pathology here. So, good. So let's move on to the next case. Well, I'm not going to go into that case. Okay. Let's go on to this one. Yeah. Rotate this a bit. Right. Any thoughts?
Oh, all right. So mean, bowel looks okay to me. Chest X-ray looks okay. There's something in that neck that doesn't look quite right to me. Is it a coiled tube or something, or is that just artifact right there? Yeah. What is that?
Let me zoom in so people can see that a bit. So I'm zooming a bit there. Yeah. What do you reckon? I think you called it, Imran. So.
Yeah. Got it. There you go. Smashed it.
Nice one. So what does that tell you then? Yeah, you got half
So
an
whatever.
hour for that,
So oh yeah. Okay. So there must be. Oh, this is to do with There's another one, that esophageal atresia. That's right. So if it coils up, then you get it's an esophageal atresia. There's lack of development of the esophagus. So normally it's a continuous tube, but because it's not developed properly, the NG tube will just keep coming back on itself.
Exactly. Right, good. So, and I think a few people in the comments have got that as well. So, right, let's just go through this then. So, first things first, and yeah, I think it looks like a few people got it kind of mixed together as well in there. So, first things first, as you said, let's start with the easy stuff. So, lungs look normal cardiothomic contour, allowing for the degree of rotation. Now, one little tip I use for pediatric chest. You know how in adults, when we look at rotation, we look at the medial heads of the clavicle. I often just look at the ribs in kids, and you can see, if you look at this rib compared to, say, this rib, you can see this rib's clearly a lot shorter than this rib. So it tells you the X-ray is rotated on there as well. So there is a degree of rotation, which is obscuring or making this cardiothomic contour look a little bit shifted around, but it's still fine allowing for that. So as you said, if we go back to our basics in terms of the abdomen, firstly, is there bowel dilatation? No, there's not. Is there any evidence of free gas? No, there's not. Is there pneumatosis? No, there's not. So, but we do have this NG tube, or this tube called in the esophagus. And that's why I always say, always start with the tubes on here, because this is very easy to miss. It's sitting quite high up, you know, it could even look a little bit artifactual, very difficult to say 100% on there, but clearly when you look a bit closer, you can see that there is a tube there. Now, actually, there's two tubes here. So there's this tube. Oh, this pencil's working its magic today. So there's one tube here, which is an NG tube. And I don't know if you can appreciate this. There's another tube here with a line, with a double line. I'm going to remove it in a sec. Any thoughts on all that? Now, if I zoom out, you might not appreciate.
It's an ET tube, no? I mean, it looks like one looks very flat and straight, where the other one looks kind of coiled.
Yeah, exactly. Now, so it's a lot of people would call this an ET tube when they look at it. But although I said there was a double line, if you look, there is a little side hole here as well. You can see there's this little gap in the middle of it, which actually helps lend the diagnosis here as well. So this is an NG tube. I think Natalie in the comments has said it's a replogal tube, which is right. So replogal tubes are used, they look like an ET tube apart from the side hole on imaging, and they're used in esophageal atresia. So now, so if we're to choose a diagnosis, I think we've said it to a degree here. Some people have got it bang on. What does this tell us? What does the coiled tube tell us? Firstly, we thought that in isolation, you said it already, Imran.
Yeah, the lack of esophageal development.
Yeah, the coiled NG tube tells you is an esophageal atresia. It doesn't tell you there's a tracheoesophageal fistula. So always be careful of that. So just seeing this tells you that basically you've just got this esophageal stump. Okay. The next thing to comment on is their distal bowel gas. So if there's distal bowel gas, it tells you there is a distal tracheoesophageal fistula in association. So the majority of these have a tracheoesophageal fistula associated with it. But if it was just this and there was no bowel gas distally, then it's just an isolated esophageal atresia without distal fistula as well. So this was a top OA.
This makes sense. So I guess like if there was no connection, there'd be no air getting to the bowel. But because if there's bowel gas in the bowel, then that must mean there's a connection between the trachea and the esophagus, or the stump of the esophagus that we have.
Exactly. The air has to come from somewhere. So there is always esophagus here, and there's always esophagus here. There's just no connection, as you said. If there was no fistula, air would you just get this big pouch in the upper esophagus, but it wouldn't go anywhere. So the air has to come from somewhere. Obviously, over time, this fistula is formed distally, and then the air is then coming from the lungs instead down into the esophagus and down into the abdomen after that.
Well, that makes sense.
So, right. So what should we go on to next? But let's keep with the abdomens, and then let's do this one. Right. Any thoughts on this, guys?
I mean, the bowel looks a bit dilated, doesn't it? There in the lower left abdomen.
Agreed. Yeah.
What else going on?
We've got
Something hepatomegaly there.
Yeah.
I wouldn't have thought off the top of my head, but fair enough.
Yeah. So atresia. It's not unreasonable thought. So
22 looks okay. Yeah, I can't see anything else beyond the bowel loops being particularly dilated on the screen here.
So this one's a little bit trickier, to be honest, over here. So, I mean, the first thing is we go back to the basic principles we said earlier. So I think we're kind of getting there in the comments. So as you said, NG tube is fine, cardiothymic contour is normal as well, lungs are clear. Now, there is dilated bowel loops, as you said. So if we look around here, left lower quadrant and the pelvis, they're clearly dilated. So then we want to basically go into territory of is it a high obstruction, mid-gut obstruction, or low obstruction? So any thoughts? Yeah, so I think Mara said it's a low obstruction. So you can see this dilated loop is descending right into the pelvis. So I know we say you can't always tell exactly where the dilatation is, but sometimes you can work it out. And in this case, we can. So we've got a very dilated rectosigmoid probably. The loops elsewhere aren't too bad, maybe a couple of dilated loops. So there is something else here, you know, but if there was no SK radiologist around, they might be able to tell me. So I don't know if you can pair it all together.
Can't remember, mate.
Yeah, so here it's
someone said it in the comments.
Yeah, so Natalie's got this in the comments. So basically the key thing to look for is, what else is there really? So we've got very dilated rectosigmoid. You've got, sorry, let me just zoom in on here. So Hirschsprung's as a comment is a very reasonable comment to make as well. Individually, I don't think it's very easy to say it's not Hirschsprung's or it's not something else. But the key things are these here. Can you see these here? There's vertebral segmentation anomaly. And you've got here in the sort of lower thoracic or lumbar region, upper lumbar. You've also got here, you've got a butterfly vertebra, or heavy vertebra, sorry, here as well. So in the context of vertebral segmentation anomalies, and you've got what looks like a low GI obstruction, can anyone pair that all together?
Someone's written it down, haven't they?
Yeah, they have. So yeah. So Natalie's got it here, which is Vactorol. So this child actually had an anorectal malformation on there, and once you associate that with these vertebral anomalies as well, you know, you can see it's part of the Vactorol spectrum as well. They had an imperfora anus. Hirschsprung is, as a few people said, a very reasonable suggestion as well. A good way to tell is to do a lower GI study as well, and that way you can at least assess the rectosigmoid ratio properly as well on there. But you know, just again, this is more of a piece it together case more than anything. Nice. Cool. Right, let's go to what should we do next? Right. So right, any thoughts from anyone on this one? I might have given it away already.
I mean, they've got what looks like a mass or something pushing everything towards the left, right? So, but I feel like you can see the inferior aspect of the liver. So this seems like it's separate from the liver.
Yeah.
So I suspect it's gonna be like some sort of renal lesion, pushing everything across. But I can't see any evidence of any calcification. So, I mean, when you've got a renal lesion, you're kind of only going down two roads, right? Wilms tumors or neuroblastomas. Can't see any calcifications in this at all. So out of the two, at this present time, I'll be looking for a Wilms tumor, and then we need to do an ultrasound and a CT scan for further investigation.
Yeah, very good, very good. So, so I'm just going back to a comment made on the last case as well about hepatomegaly. Now, in kids, it's quite difficult with hepatomegaly. Before I get on to the actual tumor, in that the liver always looks a bit bigger than you anticipate, and it can also stretch all the way across as well. So really, unless it's really descending down or it looks very lobulated, I normally downplay it on there. Here, we've kind of lost that hepatic shadow. You can probably just see the inferior aspect, as Imran said as well on there. So probably this could well be indistinct from the from the liver. But as has been commented on, there is this paucity of bowel gas in the mid-abdomen to the right. There is something else here, although it's quite faint, which might change it. I don't know if you guys can see this. Can you see anything there at all?
Where are you pointing to?
So if I draw on it.
So are you talking about widening and sort of widening of the neuroforamen there?
I think that's okay, but I think if we just compare left side to right side, it just looks a bit more busy on the left.
Yeah. Looks a bit mottled, I guess. Like maybe there's a faint calcification there. Is that what that is?
Exactly. Yeah, spot on. So there you can see it. It's some very faint calcification seen on the left. I mean, this one's quite a subtle one, not helped by the fact they're a little rotated. So does that change what you think on that?
Well, then, yeah, like I said before, and now you've got a renal mass with calcification of the abdomen, then you'd have to go down the road of a neuroblastoma.
Exactly, yeah, spot on. So if we see a calcification in the abdomen, which is especially at a later age like this, then you've got to start worrying about neuroblastoma. So we go on to the CT, and then hopefully I should have downloaded this before.
So you can see straight away there's a few calcifications, isn't it, in the upper abdomen there?
Exactly, yeah. So if we go from the top here, now pediatric CT, it's never as hard as people say it is. Things are a bit more squished together, but really you're only ever looking for so many things. So straight away, you've got some soft tissue seen here in the right posterior hemithorax, probably a bit of an effusion as well. Coming down to where the money was in the abdomen, you can see there's this very large mass seen in the upper and extending down into the mid-abdomen with foci of calcification. So you can see that one on the left that we're seeing on the x-ray. Another big chunky calcification here, the superior aspect of it. Now, neuroblastomas typically, most of the time arise from the adrenals, but then always it can just be retroperitoneal. This one, I think you can see the adrenal separate to it as well. Now, what else is there to differentiate this from? Because we always talk about, especially from an exam point of view, we're always talking how is it neuroblastoma versus Wilms. So, what are the other things that you look for normally for it?
So, you mean you're looking for encasing of the vessels, and the calcification is going to be one of them, and it's separate from the kidney, so it's not coming from the kidney. So that's another thing. I'm surprised there's you said there's a lung metastasis, because I thought neuroblastomas wouldn't usually metastasize to the lung. Have I got that wrong? Because I thought it'd be Wilms tumors that would do that more likely.
Yeah, so that's a good point on there as well. So I think in terms of lung metastasis, bear in mind that neuroblastomas obviously follow the neural crest, I think, is or whatever. So it's similar to it's more, not so much it's a lung metastasis, it's probably arising from the chest wall, or it's probably neurogenic in origin. And that effusion is probably more reactive more than anything. In terms of actual lungs, if we were to window it, you can see the actual lungs are clear on there as well once I sort myself out. Yeah, so there's no actual probably nodule. So as Imran said, I mean, important thing to realize is that actually lung metastases are less common in neuroblastomas. What we see more is bone metastases versus Wilms, where you see more lung rather than bone. So in terms of differentiating the two, the key things, so you said, where is it arising from firstly? That's the most important thing. Clearly it isn't arising from the kidney. It's more retroperitoneal in nature, and it's kind of going up towards the kidney and effacing it, but not completely, you're not completely arising from it. In Wilms, you're looking for that claw sign. The other thing is that in neuroblastomas, you would get encasement of the vessels. It's a little bit like lymphoma in that way. It often lifts the aorta up, encases the vessels rather than displaces them. And similarly, you often see it will cross the midline, unlike in Wilms tumors, where it normally stays on one side or another on there. And again, common thing as well, calcification, much more common in neuroblastomas, although you do still see it in Wilms as well, but less commonly. Cool. Right.
It's a nice case, that one.
Nice. So let's keep on going. So let's do it. I think we've exhausted most of our abdomens. There's a couple more. So any thoughts from anyone on what this is?
The lights are getting dark.
Anyone want to shout out about what's going on in the comments?
Okay, just I mean, there's a lot of, I mean, I'm going to just be really basic here. So it looks like there's a lot going on in the lung there. Look, maybe some atelectasis or something, maybe even a cavity of some sort in that left hemithorax. Things being pushed across towards the right side.
Yeah, that's a good thought. Good thought. So the money's in the left lung, really.
And because of the case that we saw earlier, I'm wondering whether they've got this. I mean, could it be a herniation again?
Yeah, so that's the
bubble herniating up. Yeah.
So that's definitely one of the things you'd think of in this case. So if you were to see, basically, we have a cystic lesion in the lung. If you were to see a cystic lesion in the lung, the most common thing is going to be two things. So some reams on it. So the key things are: could it be a diaphragmatic hernia? Could it be a CPAM or CCAM, whichever way you describe it nowadays on there? So first off, I don't know if everyone can appreciate this. You've got this thing here. So you've got this cystic lucidity seen in the left lung. Now, the other things to bear in mind if you see this are, well, if we're going down the line of, could it be a CDH, like we said earlier? Well, to see elsewhere, well, we still see what looks like a bit of stomach here. The left hemidiaphragm looks well defined still. Even then, like we're looking at the other areas as well, it doesn't really follow the configuration of bowels that you normally see. And normally the CDHs, when you see it, it's very classic. You see lots of dilated loops on there as well. Lots of loops have got into the left hemithorax as well. Similar to the other one. They will often look very, very similar on there. So this is actually a CPAM or CCAM, whichever one you want to call it now on there. And again, there are different types of these ones. So they can be microcystic, macrocystic on there. They can be associated with pulmonary sequestration as well, what they call hybrid lesions. So this is, and again, on an X-ray, never really going to tell that necessarily, to be honest. But these ones often go and end up having a CT chest as well, and they just get resected operatively. Perfect. Not much more to say on that one. I appreciate we're taking a bit more things. I'll try and speed up a bit on some of them. Right. So this one. These last two abdos are a little bit more out there. So right. So any thoughts from anyone as to what's going on there?
I mean, it looks like someone's given contrast. Looks like oral contrast, quite a distended stomach from the looks of things, and looks like the contrast has gone through into the large bowel. No, like looks like kind of, what's that large? That large bowel look a bit strange.
Yeah.
It looks kind of like it's got a little diverticular or something along the large bowel there on that right part of the abdomen.
Yeah. So, well, I think so. I think the large bowel's okay, but contrast has definitely got into it. So, but overall, we've got a very, very big stomach with, but contrast has passed through. So I don't know if windowing this helps a little bit.
But that left upper part of the stomach looks a bit strange, doesn't it? Like it looks quite mottled in the left upper abdomen.
Yeah, so that's quite important to note as well. Let me try and window this if I can. Don't know if that helps at all. Any thoughts? Can you see anything there on the I don't know. This is a bit out there, so I'm not expecting people to like jump out of the answer on this one, to be honest. So,
Someone's written something.
yeah. So, well, so Serene said, yes, I think we've got there. So I'll start with Serene's comment on here. So I think she said, could it be pyloric stenosis, hypertrophic pyloric stenosis? So key thing first, when you look at these things, whenever you see a pediatric X-ray, be it in real life or exams or whichever, always work out the age of the child. So in this case, you can see the iliac crests are present but not fused. So this is probably an older child, likely an adolescent, because they're one of the last things to fuse on there. So that they'd probably be a bit too old for that. But it's quite useful information to know as well. We know they're an older child, got a really big stomach. And yeah, there is this contrast seen within. So you would think really big stomach, could it be a gastric outlet obstruction? Well, yeah, possibly, but actually contrast has passed through fairly quickly into the large bowel as well. I don't know if you can see here. I don't know if you can see there's this. There's a big fitting defect in the middle of it as well. It's probably easier without lines, but you can see there as well.
Yeah.
So they actually did have a fluoroscopic study before this. If I get through it, you can see there.
Yeah, big filling defect there, yeah.
There's a big filling defect. So yeah.
Look like I've got two stomachs or something there. What's going on?
Exactly. So yeah, so this is actually there's a couple of people still in the comment. I think Manish in there as well. This is a bezoar on there. So this is actually, and this mottling here is hair, and that's why it has that rounded appearance. So that's an older child who had a history of psychiatric issues and obviously been eating hair over time. Bezoars are normally built up of indigestible content, so things like grass, like I said, hair, had all sorts. You had cloves, whichever, on there as well. And because the stomach can't break it down, it just sort of sits there, either there or other parts of the bowel. Either it gets passed out, but if it builds up, it turns into this very hard, solid mass, which eventually will just cause obstruction as well. And that was a nice bezoar. Right. Where do we want to go now? So right. So I'm actually going to give all three scans to begin with.
So again, multiple loops of air-filled bowel in the abdomen, but then there's also quite a dense appearance to that upper abdomen, which I assume is going to be the stomach. That's where the stomach would be.
Yeah, so it's not unreasonable on there as well. So any thoughts as well in the chat? Anyone have any other ideas as well?
I think you got everyone stumped on this one.
Yeah, I know.
People normally fly in, don't they?
I did say these two are a bit out there too. So what do we see now? So now
you've got so now you've got this now things have changed, because you did have a hyperdense appearance to the mid-abdomen, but now you've got a hyperdense appearance to the left flank, which is what someone's mentioning as well. So something's moving. Something's moving there.
Exactly.
Inside this patient.
Exactly. So that is, and if I was to tell you, so did this X-ray. First things first, when they reported it, they said, well, it looks like there's a mass in the upper abdomen. What do we do? In kids, boys, tell you what, they're on the ball today, aren't they? I think I'll tell you. So in kids, always before we go to CT, we always like to do an ultrasound first. The ultrasound, which I haven't shown you here because it probably doesn't add a huge amount, it shows a mass of indeterminate origin, just and sort of heterogeneous part of solid cystic mass in the left iliac fossa. So we've got a lesion which is in the upper abdomen, left flank, and in the middle, which is the left iliac fossa. So I will say, someone was spot on here as well. Is it Hussein? I think Hussein knows. I may have said your name wrong, so I apologize. Awesome. So if we look at this, or I should have done this again during it. Bear with me one sec. So this is a CT that we did subsequently after the ultrasound. And then almost there. So if we go to the top, now, as with a lot of things in radiology, it's not always about what you see, it's about what you don't see as well. So a lot of people look at this and not sure what's going on. Liver looks fine, spleen looks fine, allegedly. Then they see this thing. Oh, is that a bit of bowel? Yeah. So, but actually, we go up, so those bowel loops are all just non-specific, probably just gas filled, but not necessarily dilated. But you can see there's a twist in the left flank.
Yeah.
So actually, the more you look at this, the more you think, well, actually, where is the spleen? This is all just a beaver tail liver, and you can see it go all the way across. The spleen's nowhere to be seen. And as you've got here, you've got this thing. As I said, you know, in the absence of any spleen, although I'll get onto that in a second, you got this thing which said twist within it as well. So this was actually a wandering spleen which had torted as well.
Okay.
And actually, there is actually this little tiny splenunculus. So there was actually like a little bit of functioning splenic tissue as well. This which got resected. So the thing with these
spleen
ones
is moving around.
Exactly.
And then it ended up twisting on itself and ended up getting in trouble.
Yeah, so it's a certain patients get this. Normally, one has to have an underlying condition where their suspensory ligaments are much more lax. Like being honest, I can't remember off the top of my head which conditions those are. But essentially, so seeing a wandering spleen in itself is quite rare. But there's always a risk of torsion because they had a long vascular pedicle.
Okay.
So this often they present with sort of intermittent or sort of grumbling abdominal pain because they intermittently tort. And in this case, it clearly fully torted, and you had a very necrotic looking spleen in the left flank as well. So then proceeds to splenectomy.
Phenomenal case.
Sweet. Right.
Okay, should we go for the last? I think we're coming up to the last 15 minutes, and unless you've got something else, should we go for the ones that people suggest for us to look at? So someone said query cranial osteomyelitis.
Yeah.
Should we have a look at that one?
Yeah.
Unless you've got another, should we go do that? Yeah.
I've got a couple. It's up to you. Got a couple of bone cases or a few bone cases to look at quickly, or we can just do those.
Bones are boring, man. No, I'm just joking. Should we do one bone one, and then how quick will it be?
Let's go.
Okay, let's do one bone one. Go for it.
Let's do one bone. Do one bone.
Did someone do a spelling mistake on wandering on purpose? Wandering.
They're wondering about the answer. I think so.
Yeah, exactly.
Right.
Okay, so clearly very abnormal appearances to both femurs. Looks like very abnormal trabeculation. Growth plates are still present. Quite widened bones as well. And anytime I see anything like this, my mind straight away says osteogenesis imperfecta. Yeah. Bang on.
So we said this would be a quick one. So on there, so you got very, very markedly bowed bones. Whenever you see bowing of bones, you think the bones have to be quite soft. So you're thinking OI, or you're thinking something like rickets, maybe scurvy. So then you've got clearly abnormal bones, but you have all these lines, these growth arrest lines as well. And you actually see similar ones in the iliac crest as well. Any ideas from anyone what those are? That's what kind of
they must get like bisphosphonate treatment. Do they get bisphosphonates or something?
Exactly.
The wrong one. They do. Okay, so they get bisphosphonate treatment. So you'll see that they'll have very regular spaced lines because they get regular bisphosphonate treatments.
Exactly. Yeah. So these guys have the ones that are on bisphosphonate therapy have what we call zebra lines, where they have these multiple growth arrest lines as well. So that's quite classic of osteogenesis imperfecta as well. All right, sweet. Right, so we hit those last two cases up. So.
Yeah, let's get the last two cases. So it's quite nice in the the Collective Minds Radiology network. They do tag us to kind of before the actual lecture that we have or the webinar that we have. So someone has asked us about this one. So I guess we're just going to have a look through. So it's a query osteomyelitis. So I think we were looking at this one. And we're going to kind of concentrate on the bones, and the brain kind of looked fairly normalish. I mean, obviously depends what Samir thinks too, but it really was the bones which looked quite abnormal, didn't they? So you had these quite extensive absent areas of the skull calvarium, particularly in that sort of lower area there around the right mastoid air cells, it kind of almost eating all the way through to the inner ear ossicles. Can you see that? Right into that sort of middle ear cavity.
Yeah.
From what I could see. So quite extensive destruction going on there. But yeah, I mean, yeah. What do you think so far, Samir? I mean, it looks something's going on, something's happening.
Yeah, so it's clearly a destructive process going on. I mean, there's obviously it's also, I think what's important is it's multifocal. So we can see here in the left, it's sort of left temporal bone as well, but even here in the sphenoid, they're similar on the right. You know, the more you look, the more you see, and ignored air cells as well. So, but clearly here we have this area which is a little bit more complex, where you've got sort of fluid component with some evidence of some locules of gas seen within on it as well. So yeah, I mean, it's so what would, I suppose, the trades was thought what's going to cause multiple lytic lesions in the child from there.
So like Langerhans or something.
Yeah, I mean, Langerhans is what I would have said on there, and maybe there's just some form of secondary infection. You can see there's a tract to skin the surface here where this happened, or maybe they've had some sort of intervention here as well on it as well. I suppose osteomyelitis again depends a lot on the history really as well, but you know, it'd be a bit unusual to see it so floridly everywhere else as well. Although you do get like CRMO, where you get more chronic infections as well, which can be a bit more multifocal. I don't know if you had any other thoughts on that.
And then you said it could be metastasis of some sort as well, possibly.
Yeah, metastases as well. If we're thinking bone mets, then we're thinking like neuroblastoma mets as well. This area does throw you off a little bit in terms of the two things that we've said on there as well, and then it does look a bit more complex. But in isolation, if I was to see these, I would have thought Mets or Langerhans. But yeah, I think as Manish said as well, CRMO is also another consideration as well.
But like you said, it could be a dual pathology here, so it could be infection on top of a pre-existing condition such as CRMO, underlying malignancy, or even Langerhans, basically. Yeah. Really interesting case.
Yeah, cool. Nice.
And then and there's another one, isn't there, where they've actually labeled me, but it's not me. This is not me. It's someone else's scan. It looks like a chest CT scan, non-contrast, of a very young patient. I think they've said this patient is on high flow oxygen. And I mean, once you get to the lung windows, you can see what's going on. I mean, even without looking at the lung windows, on the bone, on the soft tissue windows, you can see there's something going on in the lungs. And straight away, you can see that the lungs don't look normal at all. Yeah. So, what do you think, Samir?
Yeah, I find pediatric lungs are very difficult to often pinpoint a specific diagnosis a lot of the time. A lot of it depends on the history. Firstly, it depends on whether the child's term or not, and how old they are currently as well. And a lot of them do look quite similar. I think Manish said PIE. I think with PIE, the only thing is you do normally get branching lucencies seen within the lungs as well. This is where you're getting essentially like what's it called, like an air leak as well on there as well.
See, I mean, when you come up to the kind of more apical areas, you can actually see the hexagonal appearances of the lungs. That looks like sort of interlobular septal thickening, doesn't it? So whatever's going on, there's extensive amount of fluid, plus this consolidation, plus this ground glass changes. Quite a wide differential, isn't it?
Yeah, I think this one, I mean, as you say, I think there is septal thickening as well. There's some sparing of bases. I think some people are saying alveolar proteinosis. I have to say, it's not that common in children. It's the only thing, as far as I'm aware. Don't quote me on that though.
And the non-contrast heart doesn't look too bad, does it? It looks fairly normal.
Yeah,
size.
the heart looks okay. Just some more constant consolidation. That's on this one. I'm probably a little bit stumped as to what it is specifically.
The problem is with heart findings like this, it could be so many things, doesn't it? I mean, essentially what you're looking at is what looks like fluid overload, which can happen because of heart failure, kidney failure, all sorts of things, right?
Yeah.
Infection could be causing something like this too. So much would be based on why they came in and what was going on in the first place.
Yeah.
I guess this is just a good example of what essentially perihilar consolidated changes in interlobular septal thickening, as well as ground glass changes scatter throughout both endothoraces. Yeah. So quite a wide differential on that one.
I think
but
so,
quite interesting case and a good illustration of what we're talking about. Yeah. Great. Samir, I've enjoyed this. I don't know about you guys, but I have taken a number of notes for my own learning, just so that I will hopefully be able to impart my knowledge of peds, thanks to your knowledge of peds. So from me, anyway, thank you very much. I hope everyone's had a good evening. Listen to Samir. Samir, any parting words to our guests today?
No, just to say my pleasure. It's always very nice to get a lot of different opinions and views and everything. It's my pleasure to everyone. I hope I learned something from it at least. I can see there's some very nice comments in the chat as well. So like I said, I hope you all got something out of that, and always up for doing it again if needed. So.
Yeah, I'm sure. I think everyone who's joined tonight can agree with me that this has been amazing. So thank you so much, Imran, Lasker, and Samir. It's truly, nice to see you guys go ahead on all of these cases. And Samir, you're welcome anytime you want. So, thank everyone. Thank you, everyone who's joining tonight. I will be sending out an evaluation form. So please fill that out because it actually helps us provide more value to you as participants. The reason why we did this talk with Samir Alvan today is because some of you wanted pediatric cases. We also had a couple of suggestions of chest imaging, so that's another consideration. So take some time, to fill out the form, and with the form, I'm also going to send out the CPD points or the certificate. So, thank you, Imran and Samir Alvan, and I hope to see all of you or most of you on the next webinar next month. So I will send out a registration link on that as well. And with that being said, I hope that you have a good evening, and I will see you in the next webinar.